to the VHQC Stopping Sepsis and Long-Term Care Conference call. My name is Victoria, and I will be your operator for today's call. At this time, all participants are in listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Candy Hamner. Candy, you may begin.
Welcome, everyone. Welcome to the Provider's Guide to Managing Sepsis. Dr. John Loom is our guest speaker today, and he'll be speaking to managing sepsis in the long-term care environment. Before we hear from Dr. Loom, I'd like to introduce the Stopping Sepsis and Long-Term Care team. Sheila McLean, she is the program director for Maryland, and she's on the line. Myself, Teresa Mandela, many of you know her. She's an improvement consultant with long-term care. And then also, we have our team, who we collaborate with, the Maryland Hospital Association, Justin Zambra, and with the Maryland Patient Safety Center, Bonnie DePietro. Now I'd like to introduce you to Dr. John Loom, and I'm going to give you a little bit of background on Dr. Loom. He is the Senior Vice President of Medical Affairs for Genesis Southern Area. He has clinical oversight responsibility for about 70 skilled nursing facilities in 6 states. For Genesis Physician Services, he's had several appointments, including Clinical Assistant Professor of Medicine at the University of Maryland School of Medicine. Dr. Loom received his MD from Georgetown University School of Medicine in Washington, D.C., and his internship and residency in internal medicine at Baylor College of Medicine in Houston, Texas. Dr. Loom also completed a fellowship in geriatric medicine and gerontology at the Johns Hopkins University School of Medicine. At this time, I'd like to turn this over to Dr. Loom.
Well, thank you, Candy, for that very nice introduction, and welcome to everybody this afternoon to talk about sepsis. It's a very difficult clinical topic, I believe, to speak about in our environment because it can be very ethereal and hard to get our arms around. We'll get into that a little bit and try to make as best of sense as we can about this going forward. The objectives you can see on the screen here, number one, want everybody to try to understand some schematic of a pathophysiology of sepsis and what that looks like, what happens when somebody becomes septic. Two would be able to identify the common infections in our environment that lead to sepsis. And I think this is important, as you will see, because if we can recognize these infections and treat them early on, then we prevent sepsis in essence. Three would be to understand or know the QSOFA criteria as a way to recognize sepsis in your venue as opposed to the hospital. Next would be to be familiar with an approach that I will show you that sort of outlines how to think about sepsis management in our environment, because I alluded to before, it can be very difficult to categorize things in your mind and know how to deal with things when resources are not readily available to us in the SNF and long-term care environment. And then lastly, to know the necessary resources in our environment and try to be able to put them in place and be able to engage them effectively. Sometimes those things will not be readily available, and we need to recognize that when we're attempting to manage patients with sepsis. So if you could advance to the next slide. Just to go through a quick definition of what sepsis is, a simple way to think of it is it's a generalized response to infection that involves normal tissues that are remote to the site of infection. So it's not just an infection at a local site. It's caused some kind of systemic response. It is one of the top 3 causes for readmission to the hospital from our environment, and arguably it's the most expensive cause of readmission. Now, I'm going to, at the end of the presentation, get into a study that really sheds some light on that. It's very eye-opening. it is a systemic and overwhelming nature of this process that makes it difficult to manage, as I alluded to before, outside of what we're normally used to where we're normally used to dealing with sepsis, and that's in the ICU. Next slide, please. So again, sepsis is on the rise, and I'm going to get into why that is, but the rates of sepsis and actual shock associated with sepsis have increased. You can see the statistics there per 100,000 patients since from the time frame of 1998 to 2009 in the study that I cited is pretty dramatic. And you ask yourself the question, as I did when I read those statistics originally, why is that? Why are we seeing such a rise in sepsis? Well, there's some possibilities there. The nature of advancing age in our society, increased detection of sepsis. We have many avenues, as I'm going to get into in this presentation, in detecting sepsis that we've used in the past and some we're using now. Immunosuppression could be a cause, and then multi-drug-resistant organisms. We're going to talk about that a little bit too, just touch on it briefly, but these are all possible reasons. And you also think about just the attention, the overall attention in healthcare that's been paid to sepsis. People are looking for it a lot more, through initiatives like VHQC. It has been running here for this past year in educating people in our environment about it. It really raises the awareness. So next slide, please. This is just a interesting but simple schematic to understand the pathophysiology. So the host or the patient is seated with a bacterial pathogen wherever that might be, whether it's in a distal site tissue, like lung tissue, skin, what have you, and it causes a response by the host or the patient to that infection. Now the whole tree here, or the fork in the road, is do you get a sufficient local response to that infection? Does the body keep the infection local and handle it there however it might see fit? And does tissue healing and repair occur at that site? If it does not, and it breaks the local barrier, and the response then sort of exceeds the boundaries of that local barrier, and that's where sepsis comes into play. So if you think about a specific type infection, you think about pneumonia and how that is localized to the lung tissue. It is managed there, it stays there, and the patient improves, responds, heals, and gets better. If not, and it progresses, it's not treated in a timely manner, or it's not treated correctly, or it's not treated sufficiently, it creates this more systemic response that leads to sepsis. So next slide, please. So again, we talk about how the host response is relevant to what goes on here. The host response is mediated by macrophages and leukocytes. The macrophages, if you remember, are cells that if you will, sort of eat foreign tissue or infected tissue. They also secrete pro-inflammatory cytokines, which don't help the matter when a patient is infected. The other thing to note is that nitric oxide is released by endothelial cells. Remember, the endothelial cells are the cells that coat the inside of blood vessels, and that causes vasodilation. So when the nitric oxide is released in massive amounts, you get this vasodilation of the major arterial tree, the arterioles, and that's what causes eventually the drop in blood pressure. Prostacyclin contributes to this as well, and we're not sure what mediates the prostacyclin release, but that happens also. And then you see decreased vasopressin. Now remember, vasopressin is ADH, or what is known as antidiuretic hormone. Antidiuretic hormone normally, when it's in sufficient amounts, causes the kidneys to retain water back into the tissues, and that's what ends up concentrating urine. At the same time, antidiuretic hormone constricts blood vessels or the arterial tree. So you really have sort of the worst possible things physiologically that's going on here. So at one point you have nitric oxide that is causing this massive vasodilation, and at the same time the safety net in your kidneys, which would retain fluid and volume and also help with vascular tone, has failed as well. So you're losing your volume through your kidneys at the same time that you are not able to maintain your blood pressure via an increased vascular tone. So I'm hoping that makes sense for everybody and what's going on there. So in the next slide, you see what happens in the end organs. Look at the circulatory system. As I described before, you have this massive hypotension that's occurring, and then that causes a reflex tachycardia. That's important to note because clinically, patients are dropping their blood pressure, and then they have a very high heart rate when they're septic, and this is why. In the lung, you see endothelial cell injury, and that, again, the mediation of that is not well understood, but that also leads to pulmonary edema, so you can see that. In the kidneys, with this decreased blood flow, the kidneys are very dependent on blood flow, and when they don't see adequate blood flow from the hypoperfusion caused by what's happening in the circulatory system, you get this acute tubular necrosis, so you see the BUN and creatinine going up as well. The GI system is surprisingly one of the first lines of defense sometimes to infection, and you see a decreased barrier infection because of the hypoperfusion as well. The GI cells are not getting adequate blood flow and then not performing their functions as they normally do. And in the central nervous system, you can see an encephalopathy and a decreased sensorium, and you do see that a lot of times with septic patients. Again, it's a sort of a complex phenomenon. It's not well understood, but it does happen. Next slide, please. So what are the most common infections that lead to sepsis in our venue? And they, again, as everybody, if I had to ask people prior to putting that slide up, they probably would have guessed most of them, if not all, pretty easily. Urinary tract is the most common. We see this very frequently. Pneumonia, whether it's community-acquired or hospital-acquired, occurs. And when I say hospital-acquired, I really mean healthcare-acquired, because that doesn't really do our venue justice. And I'm lumping all healthcare sites into that category. And then there's skin and soft tissue infections as well. Let's go to the next slide and talk about UTI. I think, again, UTIs have become the grab-all for everything when it comes to changing condition or infection in the SNF and long-term care setting. If somebody's not doing well, people think a lot of times, oh, well, they have a UTI, and they haven't really thought everything else out adequately. So that's what I would challenge everybody on this call to do, is to not reflexively think that when a patient isn't doing well or they have a fever that they automatically have a UTI, or if they have a change in mental status especially. There are risk factors that are well known that are associated with UTI. You can see them here on the slide: diabetes, dementia, functional impairment, catheter, when somebody has a catheter in, BPH in men, estrogen deficiency, and atrophic vaginitis in women. These are all important things to note. This is also the most common reason, as you would suspect, for antibiotic administration in our venue too. Patient has a change in mental status. doctor gets called, they want a UA, maybe a urine culture as well, and they usually at the same time will say, put them on Bactrim, put them on Cipro, put them on Macrobid. It's important to note that we've been teaching providers, physicians, NPs, and PAs over the years, and it's well established in the literature not to treat asymptomatic patients for asymptomatic bacteria. There are subsets of patients who should be treated for asymptomatic bacteria, but for our patients, for the most part, these people are not to be treated, and we see a lot of that going on. It is not good for antibiotic stewardship. It's not good for potential resistance. And I frankly think in our venue it's what's led to a lot of the problems with resistance down the line. Next slide, please. Second one on the list was pneumonia. And pneumonia is a well-known foe for us in our venue. And thinking about what are the organisms that we're dealing with, strep pneumonia is still the most common organism. No matter what venue we're really, where the patient came from or where they are at that time. We're starting to see a higher incidence of gram-negative pneumonias in our venue, and again, that's mostly because of hospital-acquired infections that are coming to us downstream. It's also important to note that we do see a lot of secondary bacterial pneumonia from influenza outbreaks in our buildings. Hopefully we're not seeing a ton of influenza outbreaks. Every few years we do get a lot of influenza because of some aberration in the coverage of the influenza vaccine with the current strains that are in the community. So it is important to note if you had an influenza outbreak, your more vulnerable patients will be susceptible to these secondary bacterial pneumonias after they've right after they're getting over their influenza. So it's important to note that immunization is still our best weapon. Pneumococcal immunizations, with also paying attention to how to do that appropriately, not only with the Pneumovax that we've used, but with the Prevnar now as well. And to continue to immunize our patients each year for seasonal influenza also is extremely important for all the reasons I talked about above. Again, in the literature, in our venue especially, the risk of multi-drug-resistant organisms, or the MDROs, is higher if you have a low ADL score and or have received antibiotics in the last 6 months. Again, you would guess that, but it's well established in the literature and good to think about. So if you have patients who are very dependent, bedridden, not feeding themselves, etc., and they're receiving antibiotics, this applies to probably a lot of our long-term care patients. But it goes to show that those patients in particular are patients that we should think very hard about in our antibiotic prescribing and be better stewards of antibiotic prescribing in that long-term care population. Next slide, please. So getting to skin and soft tissue infections, again, Staph aureus is usually the offender. In SNF and long-term care, we see a lot of people come over from the hospital with some sort of vascular access, usually a PICC line. This is the most common avenue that Staph aureus is introduced to the skin. There have been reports of group A strep outbreaks in nursing homes that still to this day happen. It is possible. So that is an organism to think about as well. And I wanted to say that, just to get this out there, that sepsis from pressure ulcers is rather rare. I still see people a lot of times referring to that a patient is septic from an infected pressure ulcer. Even usually most of the time, and this is nothing's ever always or never in medicine, but most of the time you will not see a patient become septic from an infected pressure ulcer, and those ulcers are, if they are infected, best treated with debridement and local interventions. So just to say something about MDROs, I just cited some studies there that show the MRSA and VRE penetration of colonization in long-term care patients. It's rather high. Again, it's a wide range, 10 to 50, 10 to 45, but if it is up to 45 or 50, again, that's something to be concerned about. And those are 2009 studies, so you can only think of what it probably is now if it was re-estimated. And like I said before, gram-negatives, not only in infections, but in resistance, are on the rise. Next slide, please. I wanted to talk about QSOFA. This is a new concept that was introduced at sort of the end of last year and has been talked about at the beginning of 2016 as a way to identify sepsis in patients who are outside of the ICU venue. So again, the SOFA criteria was developed for the ICU patients. And it stands for the Sequential Organ Failure Assessment, and you can see they're sepsis-related. And that is used, like I said, for ICU patients. They then decided to create a QSOFA, which is a much more general and simple way to assess sort of, if you will, outpatients, or, like I said before, people who are outside the ICU. And I'll get into what that score is and how you calculate it and assess it. It's important to note that prior to 2015, we were looking at what we call SIRS, the SIRS, or Systemic Inflammatory Response Syndrome. This was sort of the precursor to sepsis, or a clinical precursor, which was a way to help clinicians recognize patients who were maybe progressing towards sepsis. That criteria has fallen out of favor. That definition has fallen out of favor, mostly because it did not. It had a poor mortality prediction rate, and there were many hospital patients who had SIRS, who were screening positive for SIRS, but did not have infections at all. So sort of a poor sensitivity, poor specificity, and reason why QSOFA and SOFA were developed. So we'll go to the next slide. This is a little diagram that is sort of, I guess I was trying to be funny here, but you can see there's three criteria, only three, and they're pretty simple. Hypotension, and they define that as systolic below 100, altered mental status, and tachypnea of a respiratory rate of just above 22. So if a person has two or more of these criteria, it suggests that they are at a higher risk of having a poor outcome, or it suggests, and again I use the word suggests, that they might have sepsis. It is not diagnostic. Next slide, please. So this is an example of a algorithm. I was going to say schematic. It sort of is schematic, but it's really an example of an algorithm that we've worked up to help sort of all providers, nurses, NPs, physicians, to sort of how they think about sepsis. And I apologize, I was not able to sort of make it larger and fit the entire thing in one slide, but I'll just speak to it that it really, what it does is get providers to think about the identification of these patients and how to begin to look for them. It basically gets into that first diamond at the top, which gets what it says in there is evidence of infection and meets QSOFA criteria. So it gets people to start thinking with the QSOFA criteria. And then the yes, if they do meet QSOFA criteria, it takes them further down the algorithm. and really talks about having the nurse organize the information to speak to the provider, to hold blood pressure medicines, and really to review the patient's wishes, review their existing information about hospital transfer and their wishes. And then really the key to this algorithm is that large diamond toward the bottom, which really addresses the fact that it says, does the patient meet criteria for treatment in the facility? It says, does the patient have a stable blood pressure and pulse? This is very important. And even if it's abnormal and there's no evidence of septic shock, and the facility can start IV fluids, IV antibiotics within 2 hours, and or the patient has limits on hospital transfer. So really the takeaway from that diamond is to think about the patient in terms of stability. Are they stable? Yes or no? Is there evidence of septic shock? Yes or no? Can we, in the facility, start IV fluids and IV antibiotics in a timely manner? Yes or no? So these are things that it's sort of forcing people to think about. Again, sepsis, I'm going to reiterate this, it's very difficult to deal with in SNF and long-term care. A lot of times there's not a right answer, but I think if you are going to think about what is the right answer, it's what's in that diamond. Is the patient stable? Is there evidence of septic shock? And can we deliver the treatments, the fluids, and the IV antibiotics in a timely manner? And then it gets into talking about whether the patient needs to be sent out or not at the bottom. The decision tree gets into, on the left, managing the patient in the facility, starting IV fluids and IV antibiotics, or sending the patient out 911 on the right for all of the really criteria we talked about above. Next slide, please. So just to look at lab results, and I make a point, I just put this on here because lab results can be a clue a lot of times as to what's going on. A lot of times we look at lab results to help make a diagnosis. I'm not going to get into this, but if you assess patients, all the literature shows that from back as far as 1960, that history and physical are not help make 90% of a decision, of a clinical decision, and that anything else outside of history and physical, whether it's labs, x-rays, what have you, contributes about 10% to that decision. And that has been restudied twice since 1960, and it still holds true today. So lab results, again, should not be the only thing that we're looking at when we're trying to diagnose sepsis. There is not one test that's diagnostic in sepsis. That's important to note. There's not one test that's diagnostic. Altogether, though, these following things can be suggestive of sepsis. The white blood cell count, it can either go high or low. You usually see it high. The glucose will be up a lot of times in the absence of diabetes. The C-reactive protein, which is an indicator of inflammation or increased inflammation, is usually about 2 standard deviations above normal. The INR and the PTT will be out, as we call it, because of sort of diminished function in the liver, which creates your coagulation factors. The platelets will be down below 100,000. Your bilirubin will be above 4, and then you can also see this phenomenon related to adrenal insufficiency, which is low sodium and high potassium as well. Next slide, please. And continuing along the line of lab results, you look at serum lactate. You hear a lot about serum lactate when it comes to sepsis. You read a lot about it in the literature. But again, it is not diagnostic. It's consistent with sepsis. A serum lactate of greater than 2 indicates that it's possible that a patient has sepsis. And all that comes from is the tissue and organ damage that's being exhibited from the decreased blood flow to the periphery. A serum lactate above 4 is consistent with severe sepsis. And if that's the result and sepsis is somehow suspected, then things are taking a turn for the worse very quickly. Again, I want to say it's not diagnostic. Lactate is not diagnostic. In the ICU, they actually follow the lactates every 6 hours usually, or sometimes more frequently, to see if a patient is turning around with treatment. If they've established the diagnosis of sepsis and are treating it appropriately. And then I wanted to say one thing about serum procalcitonin. There's been a lot in the literature, and I've actually heard in talks about using procalcitonin as a way to diagnose sepsis, and that was supposed to be the silver bullet as the one blood test that was going to diagnose sepsis. But again, found out that it also had a poor sensitivity and specificity, and it is associated with bacterial infection, but again, not diagnostic of sepsis, and I just wanted to reiterate that. Next slide, please. So if you look at the sepsis continuum, you have sepsis, severe sepsis, and then septic shock, or actual shock, and the way to think of it is, the infection in sepsis, infection's identified, your Q-SOFA criteria has triggered positive, but the patient's still alert, and possibly the systolic blood pressure still could be relatively intact. It's possible. In severe sepsis, the systolic blood pressure will definitely be down. You'll see these adverse lab findings that I discussed previously, and the lactate will definitely be above 2. And again, so this is a picture, it's not one thing, but putting the entire picture together. And then when somebody's in septic shock, they are clearly unstable. They've had vascular collapse. That's evident by your assessment. And if you were to draw a serum lactate on that person, it would be well above 4. Next slide, please. So, how do you manage sepsis? And this is, again, I'm going to get back to when I was looking at that algorithm. You always have to use, as a provider, your clinical judgment because the presentation of sepsis is, as you can see, can be a little bit all over the place. You have to think about diagnosing and treating infection, and the mainstay of treatment is not only treating the infection or the underlying infection, but the fluid resuscitation. If you look specifically at, just specifically but simply, what are the medical goals of turning somebody around who has sepsis? It's to maintain their systolic blood pressure, to maintain a good urine output, and to clear the lactate from their system. So that's sort of how providers, especially in the ICU, think about how to turn somebody around with sepsis. And are they making progress? Are they successful in treatment? Next slide, please. So what are resources that we think we need in our venue to treat sepsis? And that's a loaded question because these days, I'm going to make some commentary on that as we go through this, but you have clinicians. I think you need an astute nursing staff. You need an astute nurse who has good assessment skills because, again, this is not one thing. You can't point to one thing and say, oh, this person has sepsis, whether it's a clinical finding or it's a blood test. It's a picture you have to put together, as you can see, and it can be very difficult to recognize. I find that on-site physicians and NPs and PAs are a tremendous help and support to what's going on because they can go, a lot of times if they're there, right to the bedside and try to get ahead of things quicker than possible. And possibly even if they're assessing patients daily, pick up on infections, some of these infections that we talked about, the common infections, before they lead to sepsis. If we start thinking in terms of referring to guides and protocols, it can help. But again, sepsis is probably one of the more difficult, if not the most difficult condition to think about a guide or a protocol because at least diagnostically, it's all over the place. I think as a facility, you have to think hard about what is your lab testing capability. Do you have rapid turnaround? Is it same day? Can you obtain IV access in a timely manner? Do you have, what's your availability for IV crystalloid solutions and IV antibiotics? Are they on site, or do they have to be delivered from the pharmacy, and how long does that take? I think all of these things play a very important role in us thinking about our ability to manage sepsis on site, whether we can do it or not. And if we do want to do it, what do we need to have in place? X-rays, and then we've looked at telemedicine as well to maybe even augment what we're doing after hours to put providers at the bedside to actually help with that as well. Next slide. This is a very interesting study that I come across a little while back that I wanted to share because I think it really illustrates what the issue is with sepsis here in the healthcare system. This is a very insightful study that was done at UCLA. It was just published last year in Critical Care Medicine. It was a retrospective analysis of California hospitalizations from 2009 to 2011. So this was just the state of California, and it was not payer specific. And it looked at the three conditions, sepsis, CHF, and acute MI. And it looked at what it looked at all the hospitalizations in that 2-year period, what their 30-day rehospitalization rate was. And it looked also, I lost my place here. Looked at the cost, which I thought was rather insightful. And as you can see there, it's pretty evident that the 30-day readmission rates are not all that much different. CHF is the highest, sepsis is number 2, and acute MI falls a little bit below them. But the cost is striking. And again, it's a lot of money for each condition, $142 million per year for acute MI. $229 million per year for CHF. This is associated costs with readmission, all costs associated with readmission, and $500 million a year for sepsis as the primary diagnosis. So you can see, if you added CHF and acute MI together, it does not equal sepsis in cost. I think it's very important to know, and I think that's what's triggering a lot of interest among CMS and a lot of payers and regulatory bodies as to what's up with sepsis and how can we get a better handle on it. The risk categories, they also looked at what puts a person at risk for 30-day readmission. Remember, this is not just SNF patients. They were included in this study, but this is also outpatients, so that's important to note. But you can see I wanted to list some of the risk factors. There's younger age, male gender, Black or Native American race, higher number of medical comorbidities, urban residents and lower income, all things we would sort of expect. But again, it sort of helps sort of profile that type of patient when they're coming into your center to be aware of. So next slide. So in summary to this presentation, just wanted to sort of state what I was trying to point out in the presentation in bullet points to make it easier to digest going away from. But sepsis is difficult to recognize and to manage in our SNF and long-term care environment. It's a very common cause for 30-day readmission, and as you can see from that prior study, it's expensive. And everybody you talk to will tell you that. It's important to recognize and appropriately treat the common infections that can lead to sepsis, because if you treat them appropriately, recognize, diagnose, manage appropriately, then hopefully we'll cut off sepsis and it will not even be an issue. Wanted you to be familiar that with the QSOFA criteria. It's relatively new. It's easy to help recognize, but again, not specific and not diagnostic. Want you to know that clinical judgment and your available resources will help dictate the appropriate site of treatment. And please don't discount that. It's going to come down to those two things. What do you think about the patient? Do you think they're stable or not? And do you have the resources in the building to take care of that patient? Those are absolutely the two most important things. And again, I think to appropriately try to manage sepsis in the SNF environment, we have to further expand our clinical capabilities in diagnosis and treatment. I think that's something you're going to see in the next year or two. There's probably going to be a lot of attention paid to that to sort of help address this issue with readmissions and high healthcare costs. Because you can see from that study from UCLA that sepsis is definitely a target when it comes to high healthcare costs. Next slide. So I don't know if we have time for questions, but that's what I have, and I appreciate everybody listening in.
Thank you, Dr. Lynn. This is Sheila McLean with VHQC, and on behalf of VHQC and our participants, we appreciate you sharing your knowledge this afternoon, and we do have time for questions. And I'm going to ask our operator, Victoria, to provide us with instructions on how participants can ask a question. Victoria?
Thank you. If you would like to ask a question, please press star then 1 on your touch-tone phone. If you're using a handset or a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone. And I am showing that we have no audio questions at this time.
Dr. Loom, this is Sheila again with VHQC, and you had mentioned in your presentation telemedicine as maybe an option as a resource for facilities, and that in your company, Genesis, that's something that you all have considered. Is that something that you've actually put into practice anywhere? And if you have, can you maybe just speak to how that's been implemented and share that maybe as a best practice?
Yeah, we've implemented a couple programs. One of the psychiatric programs to help bring psychiatric services to the bedside, but another one we had implemented with the help of a telemedicine provider is to sort of help with assessment of patients by a provider at the bedside after hours, and we have piloted that in a few centers. It has been rather effective. I think it has not been utilized the way yet that we would like it to be utilized or that we thought it might be. I think there's a lot that the nurses have to really adopt it and take it on and take it on their wings. So there are centers we find where they really do, and they do a great job with it, and some centers where it takes time for them to warm up to it. But I really think it could be the future of helping our industry out.
All right, thank you for sharing where you all are with that. We do have also a clinical question. What would be some of the key indicators during the nursing assessment that a nurse would need to make sure that they're picking up on, that they're noting, and then communicating to the physician if they're concerned that they may have a resident that's showing a sign of sepsis?
Well, again, I think recent. The first place to start would be recent prior infection. So if we've been dealing with somebody who we think is infected in some way, whether, like I was alluding to, just with those three conditions, pneumonia, UTI or skin and soft tissue. If people, worsening fever, worsening overall condition, and then getting into some of the QSOFA criteria, thinking about respiratory rate, thinking about mental status, thinking about blood pressure. The vital signs are very key indicators here. As a physician, if I'm thinking sepsis or somebody else is thinking sepsis over the phone and trying to portray that to me over the phone, I will really focus in on the vital signs. I think they're tremendously important and can sort of lead you in that direction. But again, sort of prior infection and then getting into those, starting to dig into those QSOFA criteria.
Thank you. You mentioned the algorithm. I did want to share with our participants, I had noticed this in our chat box, but I just wanted to share in case some of those have not seen in their chat box, that the algorithm is included in the handout that was attached to the webinar confirmation, but we can also send you just that algorithm so it's a better picture of it if you'd like. And if you would like that, just please contact us at VHQC, and Candy Hamner can serve as your point of contact for that. And Candy's email is a part of these handouts, so just reach out and we'll be glad to provide you a copy. We did have another question that came in via chat, and it says, in a SNF, do you think we should do some intervention of a sepsis bundle, such as antibiotic and IV with certain time limits?
A sepsis bundle. I'm assuming they're talking about bundle payment. Should we do a sepsis bundle?
I think they're looking at the question. It looks like it's bundle as far as treatment. A sepsis bundle that would include antibiotics, IV fluids within certain time frames.
Yeah, absolutely. If you're thinking sepsis, those two things go hand in hand. Fluid, like I said in the discussion, fluid resuscitation is just as important, if not more important, than administering the IV antibiotics. So, very important, and I think having it on hand together is not a bad idea, whether it's normal saline or lactated ringers, associated with the IV antibiotic dosing.
Victoria, I just wanted to check one more time to see if we have any questions via the telephone line.
There are no questions at this time.
All right. Well, I'm just going to move us into some of our next steps. And some of the key takeaways that I heard today, I'd just like to take a moment and address. Really did seeing the statistics about the readmissions, really kind of hit home with me, but also what hit home even more was the physiological impact on the residents we serve if they are showing signs and symptoms of sepsis or if they have moved into sepsis. It really is, really heart-wrenching to hear the impact that it can have on their health. So to me, that's what really spoke to me the most, because I know we're all here first and foremost to care for our residents. And just some takeaways that I heard that Dr. Bloom shared is to really take a look at how you're treating UTIs. Are we treating those UTIs appropriately? Looking at our immunization plans. Do we have a system in place to make sure we are immunizing our residents appropriately? And then also knowing your residents' risk factors. As he just said, what are their comorbidities? What are their history with prior infections? We know their risk factors, then we can care for them based on their needs and be more preventative in our approach. I also heard him to say when we're assessing, making sure that we are picking up on those subtle changes in condition and combine that with the labs, that there is no one diagnostic test, that it really has to be a holistic assessment and approach to diagnosing and treating our residents. And then I also really heard him say, know your clinicians and their capabilities and their resources, and then have established guidelines and protocols in place for those clinicians to follow. So thank you again, Dr. Loom, for sharing some of those key points. We wanted to remind you of just the next steps for this Seeing Sepsis 100 initiative. And I think most of all of you have already implemented Seeing the Sepsis 100 tools. But if you are not implemented those, I think after hearing the impact that sepsis can have on our residents and the outcomes at our facilities, it motivates us to get those implemented. We will have first quarter 2016 data to you in August, so be on the outlook for some of your current data coming to you next month. We also are asking that you continue to share your facility data with us via our SurveyMonkey link. And what we have that's due is March, April, and May data, so please remember to submit those to us. And then we have recently sent out an infection control assessment tool, and we would like for you to complete that self-assessment. That does help myself and Candy and our long-term care team to know how better to serve you and what types of tools and resources we can provide you. So again, it's important that we hear from you and know your needs, and we can do that by you completing the infection control assessment tool. And then anytime you need any help, please ask. Candy's email is listed here for you, and we'll be glad to help in any way we can. Today's presentation and recording will be posted to our Nursing Home Improvement Network online community, so be on the lookout for that if you'd like to share this presentation with others. And in closing, I just ask that you take a moment. On the right-hand side of your screen, you'll see our evaluation has opened for today's program. And we ask that you take a few minutes to complete this survey before we close out for the day. Because again, we want to hear your feedback because it only helps us to improve our programs for you. So in closing, I thank you for your time and attention. Again, we have listed in the handout for you our online community where not only you can find this recording and presentation, but you can find your Seeing Sepsis 100 tools and resources. And please stay connected with VHQC. And again, thank you, Dr. Loom, and thank you all as participants for your time and attention today, and have a wonderful afternoon. Thank you.
Thank you, ladies and gentlemen. This concludes this call. Thank you for participating. You may now disconnect.